Good morning, everybody. I know many of you, but my name is Tracy Kazmersky, and as the chair of the UPMC Children's Hospital of Pittsburgh Transition Task Force, it's my pleasure today to welcome you to Grand Rounds and to introduce today's speaker, Dr. Bill Anderson. Dr. Anderson is an associate professor of pediatrics at Children's Hospital Colorado and the University of Colorado School of Medicine. After graduating AOA from Georgetown University School of Medicine, he returned home here to Western Pennsylvania to complete his Med-Peds residency and chief residency at UPMC. He then moved west to complete his allergy and immunology fellowship at National Jewish Health. As faculty at Children's Hospital Colorado, Dr. Anderson is the co-director of the Improving Pediatric to Adult Care Transitions, or IMPACT program, and director of the Multidisciplinary Asthma Clinic. He has served as associate program director for their Allergy and Immunology Fellowship and will assume the role as clinic medical director in July. Dr. Anderson's clinical and scholarly interests include pediatric to adult transitions of care, which you're going to hear much more about today, difficult to treat and severe asthma, and the incorporation of technology in medicine. He has received grant funding from the Colorado Medicaid Supplemental Funding Program and the COPIC Medical Foundation for this work. I'm thrilled to welcome Bill back to Pittsburgh, and please join me in welcoming him today.
Thank you so much, Tracy, for that warm welcome, and thank you all for coming out. It's great to see some familiar faces in the audience. My talk for today is Under Construction, Building a Bridge from Pediatric to Adult Care. And so obviously the bridge analogy comes up a lot when it comes to pediatric to adult transition, but I felt the idea of a bridge and construction is particularly important here in Pittsburgh if you just drive around for about 30 seconds. So here are my disclosures, none of which are in terms of the advisory boards are relevant to this talk, but the funding that Tracy mentioned did help support some of the work that we're doing in pediatric to adult transition. So in terms of our objectives, today we want to describe challenges unique to the management of chronic disease as patients transition from a pediatric to adult care model, identify evidence-based key elements in the pediatric to adult transition process, utilize validated tools to assess readiness to transition to adult care, and finally, hopefully implement a pediatric to adult transition program in your clinical practice, learning lessons from our program at Children's Hospital Colorado. So when we think about the ideal transition, we want to think about it more like the Roberto Clemente Bridge. We want it to be solid, we want it to be strong, we want it to be well planned. It should be high quality, developmentally appropriate, uninterrupted care. You want it to be patient-centered, comprehensive, coordinated, and flexible, and you want to make sure you're engaging the young adult and the family in addition to a multidisciplinary team of not just providers, but nurses, social workers, family navigators, schedulers, everyone that the patient can have contact with. However, more often it's like the Fern Hollow Bridge, where you end up being inexplicit, incomplete, or late. And I really enjoy this quote. Often whenever there is transition, it's a drift away from pediatric care rather than a clearly planned and executed handoff. So what are some of the consequences of this failed transition? There is been associated with discontinuity or reduced access to care, increased morbidity and mortality, increased emergency department visits, increased hospitalizations, increased costs of care, increased patient dissatisfaction, reduced quality of life, and reduced medication adherence. Now, I don't want you to think that it's all bad. We have examples of success about when transition does work well. So for example, there's a wealth of data out there looking at pediatric patients with type 1 diabetes, and they found that a clearly structured transition program from pediatric to adult care has been associated with improvement in hemoglobin A1C, decreased diabetic nephropathy, and decreased hypoglycemic episodes. In inflammatory bowel disease, there's been associated with reduced radiation exposure, decreased hospitalizations, and decreased surgeries. And then within the transplant space, there's been associated reduced decline in kidney function and also reduced graft loss. So clearly, there's great evidence out there that if you have a structured pediatric to adult transition program, you can improve outcomes in our patients. Now, the idea of a pediatric to adult transition program is not new. This guidance has been out there for almost 2 decades now. In 2002, there was the initial joint consensus statement between the American Academy of Pediatrics, the American Academy of Family Physicians, the American College of Physicians, and the American Society of Internal Medicine, where they talked about the importance of having this well-orchestrated plan to make sure that you do not have disruptions in continuity of care. Then in 2011, they had the next reiteration of this consensus statement that was introduced as the concept of the 6 core elements of transition. We'll talk about this in greater depth later on in the talk, but the idea here is that this is providing now a framework, exact steps that you can do to help make sure you're meeting our transition objectives. And then most recently, there was an update in 2018 where they focused more about going from, all right, here's the groundwork we laid in 2011 to how do we actually implement this guidelines and how can we do it from a quality improvement model. Now, recognizing that there's been now 2 decades of this planning in place, how are we doing? So there's a couple different ways if you look at the literature about how people may measure success in transition. And one common one is this transition composite measure. These are questions that are derived from the National Survey of Children's Health. They're asked to patients and families of 12 to 17-year-olds, and they ask 4 specific points. Is the pediatric provider talking with the adolescent about eventually seeing the adult provider, introducing this idea, you're going to be moving to an adult provider, graduating to one. Second, does the pediatric provider help the adolescent gain skills to manage their health? I think that this is something you're also going to hear during this talk is that we focus a lot when we say transition. I think a lot of people jump to the transfer aspect of it, which is just one tiny sliver, and it's more about self-management and empowering a patient to advocate for themselves. The third point is pediatric provider help the adolescent understand the changes in healthcare that happen at 18. So at 18, mom calls and wants to schedule an appointment. Guess what? Mom should not be the ones calling to schedule the appointment. They now have medical legal changes at that point. And finally, the adolescent had a chance to speak with the health provider privately. I'm sure we've all experienced this where the parent is driving the entire conversation, even though the child is 17 years old, what's going to happen once they turn 18. So using this survey data, back in 2016, there was one evaluation of it that said about 15% of patients without special healthcare needs and 17% with special healthcare needs were meeting this composite measure. Not great considering that has been about 14 years since we introduced it and also 5 years after the introduction of these 6 core elements. So then in between, in 2018, we have another position paper come out, provide even more guidance, and we rocketed all the way to 19%. So clearly we are not meeting our goals still. What's even more concerning for me is that over time, and you can see the references here, we're talking from the last decade of this work, there continues to be disparities in who is actually getting transition planning. You're more likely to have transition planning if you're female, if you're older, so the idea being that you're talking about it maybe at like 17 rather than starting the conversations early at 13 and 14. If you're a patient with special healthcare needs, so obviously this is the group that we immediately jump to, but patients with very simple chronic diseases need this transition planning too. If you are non-Hispanic white, you're more likely to get transition planning versus than if you are Black or Hispanic. If you have private insurance or a higher income, you're more likely to get transition planning. And also, if you don't have any associated mental health conditions, you're more likely to get transition planning. So clearly, we are leaving out a very vulnerable population and a population that also has historically not benefited from healthcare the way that they should have. So recognizing this, how do we build this bridge? How do we make this transition process better? And I'm going to focus, I think, on 3 core elements. One is follow the blueprint. We know the guides of how do we do it, but we have to implement it consistently. Secondly, Build the infrastructure. We need to make sure that we're actually finding a way that we can do this. And third is understand the journey that a patient is on, all right? Along the way, we think about transition, but there will be potholes, sinkholes, if you will, that arise as we move on through this. So I referenced the 6 core elements a couple times now. I want to talk about what these are. The first one is a transition policy. This is a way so that your patients are clear that this is going to be the standard of care that they're going to transition to an adult provider. Now, we understand that there are situations where you may not transition to adult provider, and those would be outlined in there as well. The second step is transition tracking and monitoring. Are you tracking a patient's progress over time? Do you have a laid out system so that they will meet milestones at various ages or developmental levels? The third is transition readiness. Are you assessing the skills to make sure that a patient is able to make that transition to adult care? The fourth is developing a transition plan. All right, you've got them ready. Who are they going to? Who's their adult provider going to be? How are you going to present their medical history for the last 18, 22, 26 years of their life, depending on how old they are? The fifth step is transferring and integration into adult care. So this is the actual physical moving to an adult provider. This is the one I think everybody focuses on and gets really riled up about, because this is like the last capstone, but recognizing there's 4 steps before this. And then finally, there's this transition completion to make sure that they've actually stuck with that adult provider, they're not regressing and coming back to the children's hospital for additional care, and that they also have continued to develop the skills they need to be successful moving ahead. You do see some ages in here with step 1 being 12 to 14, step 2, 14 to 18, step 3, 14 to 18 as well, and then finally 18 to 21 and 18 to 26. I would like to point out that there's nothing magical about these ages. It is just suggestions. I would focus more on how the patient is progressing in their journey with this. So for example, you might have a patient who is very on top of their disease management and maybe could transition earlier, but others that might be struggling more, especially with associated socioeconomic issues or other chronic illnesses that they're dealing with, that may take a little bit longer. All right. This next part is a little bit about the infrastructure building. I apologize, it's a little bit of a busy slide here, but these are the elements that they outlined in the most recent position paper to how do you move this into practice. And one item is you want to integrate transition into primary, specialty, and subspecialty care. It is not any one individual, any one specialty's responsibility to be doing this. We all need to be working on this together. The next is to incorporate the 6 core elements into your EMR and workflows so that it becomes a standard part of your practice and not something extra that you have to remember on top of it. You want to support QI processes, so you're constantly going back and looking at how you're doing with this process and finding ways to improve upon it. You want to engage adolescents, I'm sorry for putting that twice, young adults and families along the way. This is certainly one of the most key aspects of it, because you can have the best laid plans, but if they're not buying into it, it doesn't help you out at all. You want to articulate transition roles and responsibilities among providers and systems. So you recognize if you have a care team, for example, in my allergy practice and asthma practice, I'm the provider, I'm the one who's helping to guide this process in terms of what is the medical management plan, but my nurse comes in with great education and helping with what's happening outside of the home. And then if complex situations arise, reaching out to a social worker to maybe help with medical legal issues, so understanding this kind of interdisciplinary work. You want to increase the availability and quality of care coordination. You'll hear about this during our talk, but having a care coordinator help a patient through this process has consistently been demonstrated to benefit the process and to result in better outcomes. You want to address guardianship and power of attorney as needed. So obviously a lot of our patients may not have the capacity to make their own decisions for themselves. And you want to make sure that you're addressing this process well in advance, not scrambling at 18 whenever maybe a crisis arises and you need to be able to address these situations then. You want to expand pediatric consultation for adult clinicians and vice versa. So our patients, because of the great work you're all doing, are living longer and having better lives. But now adults are not necessarily prepared to take care of those patients. And frequently we'll hear, oh, we don't have an adult provider that we can go to. Well, we can find one, but we need to educate them as well. And finally, you want to list community resources and accepting adult clinicians for these patients. So that's the infrastructure part of it. And finally is understanding their journey. So I think we often get caught up in this model here where we have the healthcare system, you're in pediatrics, you're gonna have a little bit of a chaotic point to transition, and then you're gonna be integrated into adult care. However, what the patient is actually seeing is all of this. They're seeing their health with it waxing and waning over time. They're seeing what the parent's role is in it, going from somebody who's educating and advocating to now kind of supporting and eventually aging out of the process. We think about the medical legal aspects of this for some patients and how chaotic that could be and how we need to obtain guardianship or even something as simple as an ID for patients. We think about the insurance and the changes that occur now, fortunately, around 26 versus younger ages, but you still can have some discrepancy in that. And then finally, they're also going through their own education. So think about whenever you were all 17, 18, I'm sure you were thinking much more about where I'm going to go off to college than you were about who's my doctor going to be once I actually get there. So we have to understand that while we focus on just the healthcare system, it's a much broader picture. So with all that being said, it brings me to what are we doing at Children's Hospital Colorado. So we have this program called the Improving Pediatric to Adult Care Transition Program, or IMPACT program. Our mission and values is to support and advocate for all young people and their families during the transition process from pediatric to adult care through inclusion. We want them to be a partner in this. We're working to help them achieve their healthcare goals. Education, we're serving as a coach. We're not doing it for them, but we're helping them in the process, and we want them to be confident in managing their disease, and we want to collaborate with them. We want to make sure that we're fostering communication, not only between patients and families, but also between pediatric and adult teams. So let's talk a little bit about the timeline and the road that we built here. So this all started back in 2016 when we had our Pediatric Adult Transition Steering Group. I think this would probably be similar to the task force that you all have. And then as part of that task force, in 2018, we launched this epic tool called the Transition Planning Tool, which I'll talk in depth later on, so I just wanted to at least put it out there for you. And then we also put together a hospital-wide pediatric adult transition policy. In 2019, myself and Jennifer DeSabato, who's a DNP that works in epilepsy, were named the leaders of this program. And then we started to really go in depth into it. And we conducted a hospital-wide need assessment, which I'll also talk about in a second here. Then you may or may not be familiar with this. We had this pandemic thing in 2020, and it kind of threw us for a loop. We had to kind of take a step back a little bit, but we tried to keep moving through it by engaging stakeholders and governance group members. And by that, we mean you all out there who are doing this work on a day-to-day basis. What are you doing in your clinics? How can we share data with each other? How can we build that infrastructure as a team? And from that, we made 4 work groups: an adult model of care work group, an EPIC TPT work group, an education work group, and a resources work group. Then in 2021, we were very fortunate to apply for and get a grant that helped propel the next phase of this, called our Impact Navigation Hub, which I'll also talk about. And we also revised our EPIC tool. In 2022, we were able to secure a second year of funding from this EPIC grant. And then we started to branch out a little bit more in what we're doing with EPIC in terms of putting in a referral from the Children's Hospital to the Adult Hospital, and also referrals to our Impact Navigation Hub. Then here in 2023, we developed a Med-Peds consult service, strategic partnerships with our adult counterparts, and developing internal funding opportunities. So with that as our roadmap, I want to delve into a little bit of depth with this, with the idea being, this is how it worked for us. It might be different for you and your practice, but I think that these are lessons that I would like to have you learn about from our successes and our failures. So in terms of a transition policy, our initial policy came out in 2018, and then we revised it in 2022. We made sure that we had input from medical leadership, surgical leadership, the patient experience team, and the Family Advisory Council. And we wanted to draw upon evidence-based literature and national best practice guidelines. And some of the key points from that is that it does establish transition as best practice. And I can't emphasize enough how important it is to have the hospital backing, saying this is the goal we're all moving towards. It's not just you as one individual provider doing it or you as one individual provider doing it. It also outlines our commitment to the families and the patients. This is almost a little bit of a contract between us, saying we're going to work with you to help facilitate that move to an adult care model. It also addresses the timeline of starting the process and when to transfer. This question comes up a lot. So we recommend starting having these conversations early, at 14 years of age, with the goal of transferring by 22. Now, we understand that there are reasons why you may not transfer or why it might be delayed. If there's a quality or safety advantage, we want to keep you at Children's. If there is not an adult provider we can readily work with, we're not going to send you out there without somebody on the other end to help you. We understand that there's different life circumstances or potentially patients who have abbreviated lifespans that we're expecting, so we don't want to transition them if they're not going to be around for the next few more years. And then finally, we want to make sure that we're keeping in mind decision-making capacity and developmental capacity when making these decisions. And then also, this clearly communicates our medical legal challenges that happen at 18 years of age, changes that happen at 18 years of age, and what that entails. So that was our policy. One of the very first things that Jen and I did when we took over this role was we did a comprehensive needs assessment. And I like to think about this as the state of transition for Children's Hospital Colorado. What are we doing well? What are we not doing well? Where can we improve upon it? We did individual interviews with about, I don't know if that's all, but 29 different clinics or sections. And then we followed up with a survey based on common themes that we got. And we asked them about what suggestions they have for improvement, what are their existing transition resources, what's their staffing, do they have any partnerships with the adult side, and any novel initiatives or funding they have. And from this, we came up with 3 main domains that we need to focus on. The first being education. We need to educate our providers and our nurses and our staff about what is the best practice for transition. The next is communication. We need to have consistent, coordinated messaging. I'm sure you have all encountered this where Dr. A says, you're 22, it's time for you to go, and Dr. B says, you can stay with me as long as you want, and then the family's now pitting you against each other. And then finally, access. So you want to make sure that you have adult providers you can go to, and then also work with those medical legal changes that happen at 18. We also then met with Family Advisory Council members, and I cannot tell you enough how important this is to get their input. They are the ones who are going through this process. Obviously, with it being in 2019, 2020 that we were doing this, it was a challenge to connect with them, and we're still working to bring back some of those connections, but we still have them involved actively in our work. So just to give you an idea about where we were with this needs assessment, only 3 of those 29 groups were using all 6 elements of the 6 core elements, and 4 recognized that they were using 5. So the vast majority were not doing what was evidence-based guidelines for this. In terms of staffing, they had a lot of people that were interested in the work, but not necessarily always practicing it on a day-to-day basis. And then in terms of a transition process, 8 said they had established formal processes and 5 said they had no process, and the vast majority fell in the middle, where it was maybe I reach out to this doc I know on the university side, shoot him an email, maybe give this one doctor a call, wait for her to respond back. So there's not necessarily consistency that was in place. So we then took that framework of education, communication, and access, and we decided that we needed to build tools for this. So in terms of education, we made provider-focused videos that provided education. We call them altitude videos. I don't know if you have something similar here. Quick on-demand 2 to 3 minute videos. We made extensive patient handouts. We also developed this Impact Navigation Hub, which we'll talk about. In terms of communication and education coming together, we had patient handouts, we have a patient website, the transition policy does that. We did this Epic tool called the TPT and made a SharePoint site for a place for all of these things to come together. And then finally, we also worked with EMR transfer orders, guardianship support, and transfer summaries. So finding ways that these tools can help meet these buckets or these needs that we have from our healthcare teams. So we also developed these interdisciplinary work groups. So these were groups that were made up of actual providers, nurses, social workers, family navigators, anyone who is interested to help develop these resources so that we get a multidisciplinary view of this. And I cannot emphasize enough how important that is. And so we had a resources and education group that developed patient and provider facing educational materials, an adult model of care group to say, what should a visit look like when a patient is 18 and they're still in a children's hospital? All too often we just assume, all right, mom and dad are coming back. Actually, not just mom and dad, but 4- and 5-year-old brother are coming back. And the whole plan's there. And we're like, no, you're an adult and we should be treating you as such. We had a separate group on medical decision-making, so specifically diving into these legal issues, because a lot of our providers recognized this was an issue, but didn't know necessarily how to go about accessing the resources they need to implement these policies. And then finally, an Epic-based tool, which we'll talk in depth. In terms of the SharePoint site, we made a centralized resource that you can go to access all these handouts, where you can find roadmaps to help with transition and evidence-based self-management education documents. So for example, if you are in sickle cell clinic and you have a really great handout that talks about transition processes, you can upload it here. We also made it a place that you can share tools with each other, like I mentioned. You can have links to best practices and position papers. And also we wanted our own internal groups that are doing this fantastic research work to know what each other is doing, so you can upload your documents there. So we have this central point that is a point of access should you have questions. And then in terms of the patient-facing website, it takes a lot of the same information, but makes it family and patient-friendly in terms of handouts linked in the text, age-based recs with self-management checklists right there in the website, and then links to like GOT transition readiness quizzes. So that is the QR code. If you want it later on, I don't know if slides are shared, but we can make sure we get it out. All right, so now we want to jump in depth into what I think were two of our biggest initiatives. The first is our transition planning tool, or what we did in Epic to help standardize these 6 core elements of transition planning. So the transition planning tool, this was a tool that was initially developed by Dr. Al Hergenroder at Texas Children's Hospital, and it provides a way for you to assess a patient's knowledge, skills, and ability to manage health issues as adults. It includes the ability to track responses to transition readiness questionnaires and access patient handouts and educational materials. And then you can view a summary of these past responses. And it has been incorporated in several children's hospitals across the nation, including San Francisco Medical Center, the Mayo, Long Beach, Baylor Children's Hospital, and then also Johns Hopkins. So we initially took this tool and we just picked up like it is and we plopped it into our EMR and said, let's play with it, let's see how it goes. And very quickly we realized that what may work at one institution does not necessarily translate exactly to what works at another institution. So we started soliciting feedback. And our feedback process went well for well over a year. And we engaged with those stakeholders who were the highest utilizers of the TPT. Not somebody who just opened it once and said, this doesn't work for me, I'm going to shut it. But people that are using it day in and day out to gather feedback on how do we improve this process. We also developed an interdisciplinary work group to subsequently say what are our recommendations and how should we implement them, and work very closely with our Epic analysts to make this happen so that it both makes functionality look good for the patient as well as the provider, because as you all know, if it's not easy to access, not easy to use, people are never going to use it. So one of the biggest feedbacks that we got was it needs to have some kind of validated transition readiness assessment built into it. So the original version did not have that. It had a lot of questions that are very related to it, but it did not have something that could be consistently used. So what is a readiness assessment? So this is a way that you can monitor a use level of preparation for adult-oriented healthcare. You can then track it over time to see how they're meeting milestones, and it has been shown that higher levels of transition readiness are associated with increased self-rated competence and adherence to disease management. So there is a way that you can track this into what will ultimately be clinical outcomes. And the one that we decided to use was the one called the TRACK, or Transition Readiness Assessment Questionnaire. It's currently in its 6th iteration. It's a validated questionnaire, and it's the most studied of the readiness assessments that's a non-categorical. That means like it's not specific to any disease state. So for those of you who are not familiar with it, I don't expect you to look at every single one of those questions, but it's 20 questions grouped into 5 different domains: managing medications, appointment keeping, tracking health issues, and talking with providers. Then patients answer questions on a scale of, I don't know how to do something, to, yes, I always do this when I need to. And so we would like to see over time you move from more, I don't know how to do this, to more, yes, I always do this when I need to. So recognizing we needed to have a readiness assessment built in. Some other feedback from our users of the TPT is they wanted to be able to see who is the person making the decisions. So we added a field that allowed you to document that. Now, recognizing that is not a legally binding field, but it's the one that we see is the one that most frequently whenever you're talking with a patient or a family, and it's also by you clicking that, you're not making a determination of capacity. You wanted to make sure, was the policy distributed? Did anyone actually talk about this in the first place? So we added that. We wanted to make sure that there was a transition summary completed. So we made sure to add that. We wanted to see if there's a way that you can identify, if we found an adult provider, who are they going to, what date are they going to go to that provider, and ultimately, can we find out if they attended the appointment? We also changed some of the questions to be more consistent with the track, as I previously mentioned. And also for this part here, we developed flow sheets that made it very clear, like green means go, you as the provider ask these questions, and blue parts are filled out by patients. And then, as I mentioned, with that part with being filled out by patients, they wanted to make sure that it's not more work for them to ask all these questions. So we built it so the track can be pushed out to patients in advance of their appointment, and then based on their responses, they'll be automatically fed back into this transition planning tool, and then you can provide education based on those individual responses. So right now, our transition planning tool has these 4 components. One is a status tab, which I'll talk about. One is the track with associated educational prompts. There is also a GOT transition, which for those who are not familiar, GOT transition is a website that has excellent information about transition on it for patients who have intellectual or developmental disabilities, so that their parent or caregiver can complete that part of it, and associated education with that, and then a synopsis. So what does this look like? So you will see this is in a flow sheet form. There are 2 questions asking about the importance and readiness to transition. These are actually validated questions, and you can actually bill off these questions. You're not going to get a ton of RVUs, but there's something that's at least there. Then you can see who's making the healthcare decisions. Was the guide provided? Was a summary provided? Who's the adult accepting a provider and all their associated information? Was there a transfer of care completed, and what was the date of transfer? So you'll see here that whenever something is filled out, it is subsequently viewable to everyone. And so this is also a way to promote communication between teams, and I have to emphasize that importance. So for example, if I'm an allergy and I'm thinking about transitioning my patient, and I go into this tool and I see, oh, cardiology has actually talked to them as well. Maybe I should be coordinating with cardiology about how we're going to make this transition happen. Or similarly, I pull up the transition planning tool and I'm like, I know this patient sees 3 other specialties and no one has put anything in here. Do I need to talk to them about what their transition plan is? We've already talked about the track and its associated domains that are there. We also added a separate one on insurance education, because while it's not part of the track, it's clearly something that's very important for our patients to know. And so what will happen is once a patient fills out the track, they'll get their responses filled in blue, which you can see here. And then us as providers can then provide education based on what we see there in green. And we can document it. So for example, this person provided a med list for their patient so they can learn about that, and also role played a situation where they could fill out or refill their prescriptions. This work is going to be done between 14 and 22 years of age. So I emphasize to people, don't panic when you see this. You don't need to do it all at once, but it's a way that we can see the progress over time. And then we do have this synopsis tab that allows you to see, all right, who's been working with this patient? What have there been responses? Is there discrepancies? So for example, a patient is much more prepared in the cardiology world than they are in the endocrinology world. Why is that? Do we then stagger their transition? How do we orchestrate that plan? So we have a tool in Epic available for everyone to use. Another tool that we came up with was this dashboard, so that you can actually look preemptively, if you wish, to see who are the patients that you need to be doing transition planning on. So this is for patients who we feel are appropriate for transition education. That would be that they're 14 years of age, they're an established patient. We don't want somebody coming in for a new patient appointment and all of a sudden being talked about moving to adult care. We want to make sure that they've had at least 2 follow-up visits in the last 30 months, indicative of this is a chronic condition that they're likely going to be continuing to come back for, and they have an appointment in the next 30 days. And with this dashboard, you're able to then filter down to level of the specialty, the department, even the provider, their age group, the medical complexity score, and whether the TPT has been used previously or not. And then you can say, all right, based on this list, I have these 4 patients that are coming in this week. Maybe I should really talk to them about transition planning. And subsequently, once you do use these tools, we have a reporting dashboard. So it allows all those individual fields that we talked about for those to be reported back to you to understand how successful you are. Did they fill out a track? Are you providing education? Did you provide a transition guide? And so on. And similar filters here, we did add a financial class, which essentially is their insurance and then their individual plan as well, so that you can say, all right, maybe I need to work more closely with my Medicaid population. Because as we mentioned previously, those are the patients that do not necessarily get the best transition planning education. So I just kind of want to show you briefly what this might look like. So this is a graph of, this is every medical specialty, so I apologize for the busyness at the bottom here. But I wanted to point out for some groups that were more successful, why were they maybe more successful? This dark blue band here is our adolescent medicine program. They've been by far the most successful because they were early adopters. They embedded the transition planning tool into their normal workflow. They embedded it into their notes, and they have a care coordinator that works with them. So that shows you when you do everything right, what that might be. These 2 colors here are neurology and rheumatology. They have worked closely with our Impact Navigation Hub, which I'm going to talk about in the next slide. So they've been working with it. And then, not to pat myself on the back here, but this one that jumped up really high is allergy and immunology. And the thing that we did is we embedded it into our note and made it part of our standard flow that every patient who meets this criteria is going to get this questionnaire. And so that way it's right there in front of you. You can delete it if you want to, but it's there so you can address this with your patients. So definitely working to make this systematic, integrated, making it something that's part of everyday practice leads to increased utilization. It makes sense, but we have the data to show it as well. All right. This next thing I want to talk about here is what I think is one of our really unique, innovative features that we've made here at Children's Hospital Colorado, and it is our Impact Navigation Hub. So this is a unique team that has 2 main roles. One is they're a clinical coach, and they help advise individual clinics and practices on best practice for transition. And then also we serve as a referral or consultative service for our more complex patients. And our team members include Barb Happ, our nurse care coordinator, Shelley Heinrichs, our social worker, Juan Ramos, our family navigator, and not pictured here is Eleanor Floyd, who's a Med-Peds provider who works in our adult special care clinic. So for those patients that might need some more complex care in adulthood, she could talk to them about some of their unique issues to kind of serve as a third party to help resolve some medical issues with them. So in terms of our goals, we want to promote communication, we want to educate, we want to improve access, we want to make sure we have that individualized, uninterrupted, streamlined care, and we want to make sure our model is replicable and sustainable. So hopefully this is something that you can all learn from as well. So when our Impact Navigation Hub does the coaching or working individual with a program, the first phase is what we like to call the infrastructure building. So they're going to do a survey with them to find out what they're currently doing. They're going to work with them in clinic to see their workflow processes, understand what they're currently doing in terms of transition work. Then they'll create individual tools that will help them with these processes. And here are some of the tools that they do. So they have these workflow maps. They help them develop specific transition guides for their patient population. So for example, we take that policy and tailor it a little bit to be language that's appropriate for a certain disease state. They help them develop a summary letter template. They help them with transition resistance, so that patient that says, I'm not going anywhere, or I'm calling the news because you're kicking me out of the children's hospital. Like that, what do we do with those patients? We have our internal referral guidelines for how they come back to us, and we provide them with some adult epic dot phrases and tips, as well as adult community providers that we've worked with. So that is the phase one. And then we work through this through a PDSA cycle to see how they're progressing. Phase two is then what we call the coaching. So we allow them some more independence in what they're doing, but we check in with them every 2 to 4 weeks. And I cannot emphasize enough the importance of the check-in process. So we will provide them with these kind of Tableau dashboards and that feedback and those charts. And what you'll see is like they're coming along, we work with them, then we go away, then we work with them, and then we go away. So it goes up and down. So you need to have continued feedback with them. And then we also make sure that they are embedding this work as a part of their healthcare. For example, like what I mentioned with allergy, with embedding that work in the note for everyone. Our phase three is a mentoring process where we check in every 2 months, once again, share these Tableau dashboards, and then ask them, are they teaching their peers within their section? So for example, within the GI clinic, we were working with the IBD population. Are those IBD nurses and providers now talking to people that are working with other GI conditions in their own section? And then this last phase, this maintenance phase, is what we're currently in development, where we want to do quarterly check-ins, but also have like a monthly lecture series where we just have a lecture available for anyone who would like to attend that reinforce topics. Let's talk about medical legal aspects of care. Let's talk about transition to adult planning. Let's talk about the TPT again, those to emphasize those aspects of it. This is our timeline for our engaged clinics thus far, and as you can see, we've worked now with 20 different programs since Q4 of 2021, and we continue to expand with the work that we're doing. And once again, this is that same kind of graph, but showing that as you engage with them, they start to increase up and move away from the pack of not really utilizing these tools. So what's been the feedback we've gotten from clinics that are participating in it? They love the dedicated support for transition consultations. They appreciated the time, the expertise, and the tools that our hub was able to provide. And they liked having a consistent structure and process to follow. The things they didn't like, they were all concerned about time. And it's once again that, oh gosh, this is one more thing that I have to do. But we're trying to find a way to break it up. Once again, that this is a process that will take years. They said that oftentimes they don't have that dedicated support, so they're being pulled in multiple different directions to do this work. And also they sometimes need increased infrastructure. For example, they don't always have a social worker. They may not have a family navigator, or maybe they could better engage the MA. So because of those reasons is why we then added on this referral or consultative service as well. So this is our referral order, but essentially what it is if you have a patient that is having difficulty transitioning, or you do not have the bandwidth to do it all yourself, we can then incorporate what you're doing with our assistance. So we can step in and say, all right, we're going to help you out, similar to a consult, to say, all right, how can we improve this transition process for this patient? And then we'll send them back to you to kind of execute the plan that we put together. So in terms of reasons for referral to the hub, you can see the top 3 here. Identification for an adult provider was the first, and we expect that to actually go down over time, because as we develop this database of adult providers who want to work with us, should see that this is going to then decrease because they can go to that database. Needs support beyond what our clinic can provide, that's going to probably stay up there for a while until you get more support, especially for smaller programs that don't have a lot of built-in infrastructure, and high-level medical complexity. So they want you just to help coordinate between multiple specialties. Once again, I think this is something that we can advance over time. And so thus far, we've had 79 referrals to our hub. We have completed, and that means moved to adult care, 46 patients. 18 have their appointment pending, but they just haven't made it to the adult appointment yet, and 15 are currently in the process. We also have here some of our additional needs that these families have these patients and families have requested. So obviously we're there to help with the medical legal issues. We're there to help coordinate care, but other issues arise like we need financial support. How do we get to our appointment? We need a school plan. How does this affect a job that I might want to do? Can you help me access mental health resources? So this is a way that we can help them in a holistic manner. All right. One other thing that I want to make sure that we touched upon today before wrapping up is the idea of working with our adult providers. Obviously, I'm here talking to a pediatric hospital, but it's been emphasized again and again in the guidelines that the adult providers have an active role in this transition process. And in the most recent position paper, they recommended that the adult provider be able to clarify medical decision-making with the patient, help them continue to develop their self-management skills, identify confidentiality policies with them, and then also be instructive with them on how their care model differs from a pediatric care model. Like, when's our clinic? How do you contact us? How do you get after hours care? So what are we doing on our campus? We are collecting population level data so that we could say how many patients of ours are truly going from the pediatric to adult world. We put in an EPIC order that then connects them from the Children's Hospital to the University Hospital. I will say that process we're still mapping out to make sure they actually do end up in the right clinic, but it does allow you to indicate the location, the specialty, or the provider. And in terms of future directions, we're working to have a multidisciplinary schedule on the university side, similar to what we have on the children's side. We want to have a dedicated leadership team, similar to what I'm doing on the children's side. And we also distinctly want to work on these room handoffs. So this is a huge aspect of it, with the idea being, is there a way we can connect all in one room, if you will, the pediatric provider, the adult provider, and the patient. And the current model we're working on through our legal team and our billing team is going to be that you're in the pediatric office with the physical pediatric provider, and then you do a telehealth visit with the adult provider there, and then that way you can obviously see and connect with each other. Being a Med-Peds person, I would be remiss to not mention our Med-Peds consult service. So this is something that just started up in 2023. This offers consultation for patients over the age of 18 at Children's Hospital Colorado, specifically providing age and disease-specific recommendations. The idea of transition does come up during this time, but I would like to emphasize that we don't actively transition or transfer anyone during those visits because they're acutely ill, they're unstable, and this is not the time to do it. But rather, they start saying, hey, you're 22, you've been admitted here now 3 times in the last year. What can we be doing to help move you along? So just to wrap up here in conclusion, so I had all of our transition infrastructure building that they recommended. I would like to say that we're working to meet all of those individual goals. Moving ahead for future development, we really want to now start assessing our processes in a more in-depth way through GOT transition clinic self-assessments, patient, provider, and family satisfaction questionnaires, looking at our data specifically about the integration into adult care. So once I put that order in EPIC, how long does it take them to get scheduled? Do they make it to that visit? Thinking about campus-wide strategic plans, and as with everything in academics, publications. So what are some of our lessons learned that you can all take home with you? I would say first, most new initiatives encounter resistance. It's going to be one more thing they have to do, but you need to make sure they understand the reason behind what you're doing. Transition also requires a culture shift. I think that there is all too often that we have this idea that yes, we should be transitioning our patients, but we don't necessarily implement it in practice, and not every section, every specialty thinks about it the same way. You also want to focus on getting the word out, which I guess we're doing today, so that people are really making sure that they understand this work is happening at your hospital and want to buy into it. These system-wide changes will take leadership buy-in and multidisciplinary stakeholder input at every level across the way. So you want to make sure that you're communicating and engaging partners. Recognizing transition is not the same as transfer, and it's a process that takes years if well done. We actually sometimes try to stay away from the language of transfer and talk about self-management skills, because people are more likely to understand that versus when I go, hey, can we help your 14-year-old patient with the transition process? So like, they're 14, they're not going anywhere. That's not what I'm talking about. Additional lessons learned: standardizing processes, improve communication between specialties and the patient provider, and advance best practices. Having refined metrics to help drive this change, and also provide evidence when you're asking for financial support for this work. Working in a coaching model where you're doing with the team versus doing for the team helps them build traction, help them understand the tools, and really helps them take ownership of what they're doing. Having dedicated clinic champions are required to sustain change. You have to have someone there who's advancing this work and always being like, all right, I'm going to see Bill in clinic. He's going to talk to me about transition. Like, I need to know that. And then finally, partnering with adult providers fosters a welcoming environment. So once again, some additional resources should you want them. There is a video about the Copic Medical Foundation and the work that we did with putting this together. We have a Charting Pediatrics podcast, which is a podcast that's run at Children's Hospital Colorado, that's done. In this one, Dan Wood, who is a pediatric and adult urologist, talks about his transition experiences. And then this Within Normal Limit podcast is myself and Jennifer DeSaba to talk about our processes. So I would like to acknowledge our impact team, who I've already mentioned, and this is our whole team here, and that's Jen, who I mentioned earlier, our pediatric and adult leaders for helping to sponsor this work, our funding sponsors, and most importantly, our stakeholders who do the work day in and day out, and our patients and families. So thank you so much for the invitation, and I'm happy to answer any questions.